Hi, everybody, and welcome to our second session of our Beautiful Dying Exit Papers 101. And we're talking today about the Advanced Healthcare Directive and planning for that, and what has this COVID-19 virus done to all of us as we stay home. We have two amazing experts in the field, and hopefully we'll be able to get through a lot of information from them and then do some Q&As. I also want to share that wherever you're at, we do have an opportunity to have you look at your own Advanced Healthcare Directive wherever you're located. So if John would like to go ahead and put that up on chat, that would be great here. And I don't know if Facebook Live shares our Zoom chats. I don't know. It's all brand new. Beta testing. So I want to introduce Dr. Karl Steinberg. He's currently president-elect of the AMDA, the Society of Post-Acute and Long-Term Care Medicine. He's the editor emeritus of their news magazine, Caring for the Ages, and an associate editor of their peer-reviewed journal, JAMDA, J-A-M-D-A. He is a past chair and current board member of the Coalition of Compassionate Care of California. And Dr. Steinberg is on the American Academy of Hospice and Palliative Medicine's Public Policy Committee, serves as vice president of the National Pulse Organization, and is on the National Quality Forum's Standing Committee on Geriatrics and Palliative Medicine. He's also been an advisor for From Beautiful Dying since 2017. So more about Dr. Steinberg. I'm sure you'll get to know him, and we'll all become this family of connection and lots of information to share with everyone. And so also on the call is Mr. John Tastad. And John was our facilitator and spokesperson in our meeting this morning, and it went very well, I think. And we're trying to make it so that it works out a lot better, knowing all these different things that are happening. Oh, wait, I got someone else being admitted here. Oh, where did she go? Helene, come back. So John is the coordinator of the Spiritual Support Services at Sharp Hospice Care and the coordinator of the Advanced Care Planning Program at Sharp Healthcare. In his 19th year at Sharp, John's academic training includes undergraduate studies at Northwest Christian University, the University of Oregon, and graduate studies at Fuller Theological Seminary and at the University of San Diego. And he's also actively involved in bioethics at Sharp and in the community. He has also been a past chair of the San Diego Coalition for Compassionate Care. And he's spoken on topics related to spiritual care and advanced care planning. So I just want to say thank you both for coming and joining us on this call. And then, yes. I guess without further ado, I'd like Karl to kind of introduce the topic of advanced healthcare planning, also what he may think about what's happening with regards to COVID virus, the COVID-19 virus, and how that's affecting his work and the people that work with him and for him. So, Karl.
Okay, thanks, Michelle. Thanks for having me. It's always a pleasure to co-present with John. John's really the advanced care planning expert. I'm kind of just a working grunt nursing home doctor and hospice doctor up in North San Diego County. And I guess just to lay a little background about advanced care planning, this is the process that people should do with their families and with their healthcare providers to make sure that the healthcare team and your family know who you want to make decisions for you if you're not able to make them for yourself, and also to make those wishes known if you have specific wishes. Lots of kind of young, healthy people may not have a lot of specific ideas about things they would or wouldn't want. Most people will say, well, I don't want to be kept alive as a vegetable, or, I don't want to be suffer greatly and be on a bunch of tubes and machines if I'm not going to come out of it relatively intact. But they might not have a more well-formed idea about what the specific interventions are and so on. So advanced care planning, and we just last week was National Healthcare Decisions Day, the day after tax day, right? Because the only things you can't get out of are death and taxes. So that's how we remember it. It's the day after tax day. Most years it is. And it's recommended that everybody over 18 have an advanced healthcare directive that at the very least designates the person or people that they would want to speak for them if they were incapacitated. So that's really a great idea. And that's one thing with this pandemic and with all of us being kind of confined to smaller spaces, and some of us with our family physically, others with our families remotely. There's a lot more time to actually consider these things. So if anybody watching this hasn't done it yet, I highly recommend that you take the time to have some discussions about this. And that's not the world's most pleasant topic, but let's face it, people, including young, healthy people, are dying of this illness. And there's really not a better time. I don't think there's ever been a better time to bring these things up, and they're important things. And as John and I and any clinician that takes care of people at the end of life can tell you, it's really ugly when people are not on the same page. And it just creates some of the most heart-wrenching situations when nobody's ever discussed it. You're now in some kind of a crisis situation, and there are warring factions about, put the feeding tube in, no, let's pull the plug. And they are so hard on everybody. They're hard for us as healthcare providers. So imagine how hard they are if you're one of those family members doing what you think is the right thing to do. Yes, I just coughed onto the back of my hand. There's nobody around except the dogs. So anyhow, so I guess those are a few things. I mean, we can talk a little bit more later about some of the more specific things that pertain to the viral illness itself, and the possible need for prolonged ventilator time. But I think your question, if I can remember back that far, was about how it's impacted my daily practice. And it's a different conversation, a little bit of a different conversation. Most of the people I look after, I've known for a while. They're not brand new to me, and we've already had this discussion. But for some people, their treatment desires or treatment wishes, preferences have changed because they say, for a nursing home resident, I don't want to go to the hospital right now. I don't want to be put on a breathing machine. So I want you to do what you can here, and if you can't keep me alive, then keep me comfortable. Those types of things. So that's something that I have seen. The other thing that's so cruel about this illness is that there is not that direct physical contact with family members. That's always such a comfort to people when they're seriously ill. And I've found that with some of my patients who have kind of mild to moderate dementia, it seems like it's the most cruel because they are used to having their family come around pretty often. And now they're on the ball enough to know that their family has seemingly abandoned them, and that sort of thing. And we can do a FaceTime or those types of things, but it doesn't really replace that physical closeness and that comfort. So, and people dying in the hospital without a family member at the bedside, very sad. In the nursing home, we are allowing people in when somebody is actively dying. For some people, it's too late to have a really meaningful interaction. But anyway, it's a real challenge with this virus, and it's going to be a marathon, not a sprint.
So thank you for that, Karl. A couple of things for me that happened just about an hour and a half ago. One of the jobs that I have gave me a call and said, "Hey, we're going back to work. Are you ready?" And I work in I stock greeting cards in stores, and I'm like, why would I want to come back to do that right now? And what does that mean? Are you giving me a raise so I can come back early. We don't know the situation that's happening. San Diego's in its crazy times right now with regards to COVID. Do you go back? Do you not go back? Um, and so she's given me 24 hours to decide whether or not I'm going to go back to work or not. Meanwhile, I've got, my husband who just had his back surgery, and am I going to go out there and, stock cards in a store that no one's buying them anyway? To, come back to have to take all my clothes off and take a shower and start all over again every night. Like, I don't think I'm going to do that. And so it's very interesting that, they're saying go back to work. And it's like, healthcare providers are saying don't go back to work. And, we have a job to do here. And so I just wanted to ask you what your thoughts are on that. When we're being told to go back to work, it reminds me of 9/11. Go back to work. The air is safe to breathe and to drink.
I think it's got to be an individual decision, and I think there's nothing that's going to pose absolutely zero risk. But by staying at home, you're close to a zero risk. By going out into places where other hands are touching and people are sneezing and whatnot, even with face masks, incrementally it's a higher risk. But for some people, it may not be a choice. It may have to, they put food on the table and whatnot. So I have mixed feelings about it. I think it's a bad idea just from a, harm reduction sort of, wearing that hat and wanting to flatten a curve. I think, this to get back out there and get things back to normal is ill-advised. And I hope we don't see too much of a blowback from it, but people are going to do what they're going to do. And the fact that this becomes a political argument is really sad, and kind of, I guess it shouldn't be that hard to understand given where we are right now, but it's unfortunate. I mean, I think safety is important. Anyway, enough blathering about that.
We had, on the call this morning, we had a participant from New Mexico who's had the COVID virus. I think she still has it right now. She's just getting over it. Is that right, John? I can't remember. Yeah. And so she, she came onto the call knowing, everything that we were doing. And it was a surprise for me to see her on the call, which was really nice. But her, her situation is like, wow, I should have taken care of my advanced healthcare directive before I started getting sick. And so she was on asking a lot of questions, and it was a really great conversation that John helped her through some of those issues on the advanced healthcare directive itself in New Mexico. So I just wanted to say thank you, John, for that. And it was a very interesting call this morning when it came to who showed up on the Zoom call. At that time, I couldn't figure out Zoom and Facebook together, but now it's on and we're live and
You're doing great, Michelle. I wanted to say that one of the things that Karl had mentioned regarding kind of when it's a real mess at the end, my work in the hospitals and bioethics committees puts me in touch with consultations when people in advance of a medical issue or a really challenging healthcare situation haven't done the planning necessary to avoid the bedside bedlam or the bedside guessing game. And from my perspective, particularly now in the midst of COVID-19, is that the most important part for people who are healthy, relatively healthy and well, is to carefully select and communicate with your durable power of attorney, with the person that you're going to put into your durable power of attorney, your chosen spokesperson for your substitute decision maker in advance, and really establish that amongst your family and your friends and your healthcare providers. And I know that even just today in a bioethics situation at one of the Sharp hospitals, we had a family in conflict where one person who might have laid claim to the nebulous title of next of kin was in conflict with another family member who was wanting to claim that position as healthcare decision maker. And the decision was to intubate or not to intubate. And it was it was a very challenging decision-making process. So selecting that trusted, well-informed, available, present advocate who could serve as your substitute healthcare decision maker, from my perspective, is really the starting point for the advanced care planning process for healthier adults.
Thank you, John. Yeah. So, what is an advanced care planning, and what does it mean for all of us now? And we're stating that an advanced care planning is for all adults 18 years and older. I don't understand why I know it's 18 because, but 16, I think 16, 17-year-olds really need to know what this advanced healthcare directive is. I think that between the ages of like 16 and 24, I think they feel that they're invincible and nothing's going to harm them, and they're superpowers. They got superpowers, and maybe they do. Maybe that's the years that you have superpowers and realize maybe you don't have them later. I don't know. But I think it's one of the things that I'd like to talk about is the durable power of attorney for healthcare, and preparing the healthcare agent to be okay to be that person. Can you expand upon that, John?
Yeah, earlier we talked about picking a document that would kind of be your repository for that person, and then the subsequent alternate healthcare agents who would only be available to serve if the primary healthcare agent is unavailable or unwilling to provide medical direction, when the completer of the advanced directive is unable to do so for themselves. And I just wanted to say that in California, there's nothing particularly magical about the documents that you might use. And many of us are really familiar with, the 5 wishes form, and here it is in Spanish. I think Aging with Dignity is making it available for free now. And it's a very comprehensive advanced directive. And most healthcare agencies have their own version of the advanced healthcare directive. And SHARP has a nice advanced healthcare directive that I think serves as a good tool for putting down your substitute decision maker and your preferences for future treatment. And I really love, as we went through this morning, Dr. Rebecca Sidori at UCSF, she put together the Prepare for Your Care document. And this website is just filled with lots of great resources for how to walk through this process. So there's nothing magical about the document. The California Probate Code and the laws of California are mostly concerned about the witnessing portion to make sure that whoever says they completed this document really was the one that completed it. And so there are some pretty strict requirements regarding stewardship of this document and the witnessing of this document. But it's really divided into those 2 places. And Dr. Sidori really skillfully said that, part 1, that most important part for healthy adults, is choose a medical decision maker. And in her document, that, there's not even the label durable power of attorney for healthcare, but that's what this portion of the form is called. It's that durable power of attorney form. And the person you put on that form has to be your carefully selected, trusted spokesperson that you're comfortable talking with about these difficult issues. And this morning we had people in the comments section on the Zoom indicate, why did you pick the person you picked to be your substitute spokesperson? And people use words like trust and availability, and one person indicated select their spouse because they would be too emotional to make decisions that aligned with the person's preferences. So they picked another family member who they knew would honor their wishes. So that first section there, Dr. Sidori also really points to giving your substitute decision maker an idea about how much leeway you want them to have. You want them to follow the advanced directive to the T, or do you want them to have a little bit of leeway? So
let me share my screen so you can see what John's talking about.
Karl, do you want to jump in and say anything about that first selecting your agent?
Yeah, I think it's probably the most important task in doing advanced care planning, and you want to make sure to pick somebody who is reasonably knowledgeable, reasonably healthcare literate, and who will serve as an advocate. In other words, they're going to advocate on your behalf, whatever direction it's in, to get you the care that you would want to get, and not whatever whatever they might prefer. And I think that is a reason why a lot of people don't choose their spouse, because, and we've both seen it many times, where the spouse will say, I know that he probably wouldn't have wanted a feeding tube, but I just can't watch him starve to death, or that sort of thing. And you don't want that person to be the one making your healthcare decisions. Although Rebecca Sidori herself has a story about, in her family, I think it was grandparents, I can't remember, but that was exactly the kind of situation. Was, he wouldn't have wanted it, but he figured if it made her feel better to put a tube in, he would let her have the leeway to do that, even though it really isn't what he would have wanted. Personally, I really don't want somebody doing something I don't want. But some people are nicer than I am, I guess. But yeah, I think it's super important to pick the right person. And many people don't do that. So I highly, highly recommend. And don't just put them down because you think they're the best person. Have the conversation with them, right? Because they may think they know what you want, but they may not actually know what you would want in a certain situation. So, yeah.
Yep.
And I wanted to say, Karl, that was really well said. But in healthcare, on the front lines, from the hospital perspective, and we generally, in the absence of a carefully selected and documented substitute decision maker, we go with the person who seems to be most interested, seems to be most present, certainly is the most available, and also someone who seems to really be willing to acquiesce to the default healthcare delivery that the hospital wants to offer, which is mostly full treatment for as long as feasibly possible. And you can see how that becomes problematic when that's misaligned with the patient's wishes. And then also I wanted to say too that the California law about next of kin is so nebulous that it doesn't really provide clear direction about how to select out of a group of family members or friends who might be interested in serving in that capacity to be the next of kin who will offer consent or assent.
Wait, yeah, you notice right here, write down anyone you would not want to help make medical decisions for you. And that's really important too, because some people do have some rogue adult child somewhere who's become a religious fanatic, or something like that. So that's super important. Yeah.
That next section about how strictly you want them to follow. This is the leeway section of the document. Total flexibility. It's okay for my decision maker to change any of my documented preferences, or some flexibility, and then you can identify. But these wishes I never want changed, or no flexibility. Follow the document. The document is our marching order, and then a way to free text about that. Those are that's not present on most advanced healthcare directives in the durable power of attorney section, and the amount of leeway that you would want to give your substitute decision maker is a really helpful component to have.
Yeah, and going back to what John said before about that we default to the most aggressive care. That is what I mean, if you want the most aggressive care, you don't necessarily need an advanced directive just because that's what we automatically give you. But if you're like a great majority of people that I look after, even those that are afraid to die and want to live a long time, most of them do not want to live sort of, in a persistent vegetative state, ventilator dependent, and those types of things. It's a small minority of people who want that, and yet that's what that's what everybody gets. So there's a little bit of a paradox there.
I'm going to stop the share. So that's the California Prepared Advanced Healthcare Directive. You can go to prepareforyourcare.org/advance-directive. I'll put it into the chat box here, but for those on Facebook, you may not see it. So I will say it again, and it's called prepareforyourcare.org/advance-directive. And you can go there and find your state and get your advanced healthcare directive downloaded from there. And
Yeah, Dr. Steinberg's put the general address there, and there are a lot of preparatory tutorials there that are helpful too. I appreciate that. That website's great. And Christy, I like your comment there about making sure that your decision maker is someone who's in close proximity. That really helps. But one of the things that a gift that COVID has given to us really has been sort of the ability to utilize technology now to render consent by a substitute decision maker. And with things like Zoom and FaceTime, we're seeing some opportunities for changes with regards to the consent process. And Karl is on the front edge of that, and some of the activities that are taken from a legislative or an administrative perspective. And do you want to comment about some of that, Karl?
Yeah, right now they're trying to get the Coalition for Compassionate Care of California and some other kind of stakeholder organizations that are trying to loosen up the witnessing requirements, at least during this pandemic, and at least in certain care settings, because normally you'd have to get two witnesses to sign off on your advance directive or get a notary to do it. If you want to do one in a nursing home, the ombudsman has to come in and witness it in addition to the other witnesses. And so that's very difficult right now with social distancing and so on, and no visitors in nursing homes. So it hasn't been granted yet. The coalition does have some suggested practices. Other thing to remember is that if you're actually in a healthcare institution, so if you're in a hospital or nursing home, you are allowed to orally designate a decision maker. And in fact, that would override a previous written advance directive. It's only good for 60 days or the time that you remain in the institution, but that's for people who are with it. I mean, they can do it on the fly. We don't recommend that, of course. We recommend having it in writing beforehand. There's also a way that people can sort of witness it remotely through sort of video technology, those types of things, and then sign the paper document through some other sort of transfer. For post forms, which are actual medical orders, normally it requires both the patient or, yep, there's our friend, the post, pink and beautiful. Both the patient or their decision maker has to sign it, and the doctor, nurse practitioner, or PA has to sign it. And so that can be a challenge too. And if you've got a decision maker who's out of state, it may be difficult to get them to sign the paper document. It's okay to fax it or to, email, scan, print, sign, send back. That's all valid, but some people don't have that technology. And so what they're suggesting right now is that if a family member speaking on behalf of someone who can't make decisions requests, for example, they want to do not transfer or no CPR order, that like two nurses can witness the oral consent to that and just sign on the post form for the time being. And we think that probably first responders will honor that, but we'd like to get it formally approved.
thank you, Karl. There's two questions. One is from a Facebook friend. If an elderly person spends time in more than one state, should they have forms specific to each state? For example, dividing time between New Mexico and Texas.
Yeah, I'll tackle that. So, by the way, elderly, that's an old-fashioned term. We don't use that anymore. Now it's all, elder, older. Things become un-PC. So I'm just putting that on your radar, right? I'm sure no disrespect meant in any way.
She's an old-fashioned kind of gal, LOL.
Aren't we all? Aren't we all? Well, except you, Josh. Anyway, so yeah, I mean, a best practice, even though it's a pain in the butt, would be to get a separate form for each state. Right now, there's work going on to try to make reciprocity with post forms, which are the actual medical orders. To my understanding, in California, if you come in with an out-of-state advance directive, chances are it will be respected. That's not true everywhere. And if it's, I mean, really an advance directive is not that hard to fill out. You know, it doesn't require a doctor to sign it or anything like that. So, but as far as the medical orders right now, those might or might not be, you know, it's very dependent on your local EMS and that sort of thing. Yeah, I don't know, John, you have anything to add to that?
You know, from the hospital end of it, if a patient came in with an out-of-state advance directive document and there wasn't a contentious issue amongst the family members in decision making, it's almost 100% sure that it wouldn't be a problem. The time that would become very difficult is if there were different family members who were wanting to be offering consent to treatment in different directions. And so, you know, how ardently a person should make sure they have two or one document in between states is, you know, is how agreeable is the family going to be in an emergent situation when somebody needs a decision regarding treatment or non-treatment. And so I think that's something to consider as well with regards to that, because almost always if there isn't a sign of, oh, there might be litigation coming from this, or there's a family in conflict, then we will honor that Arizona or New Mexico or Texas advance directive with little difficulty. So it kind of depends upon the family situation to a certain degree as well.
So another question is, that's where the box of who does not get to make decisions is so important when we looked at that particular advanced healthcare directive. I think it was in part 2, wasn't it?
Yeah, it's actually still there in part 1. Who can't be my healthcare decision maker? Right. I'm so happy that Dr. Sidori added that to her document, because I think that really clarifies that. Yeah.
So I have a question with regards to the advanced healthcare directive when it comes to your medical portal. So there's a lot of places that I've been, in the hospitals that I've been into, that don't even ask about the advanced healthcare directive. And then some of them just kind of hand you one if you ask for one. And so I got this from Scripps when my husband was going in for his surgery consultation. And so, you know, he handed his advance directive to them right before his surgery. And I'm like, well, so you have it now. Is it going into his medical portal? Are you sending it over to that department that's going to add his information in so that, you know, it's on a portal? And the other question is, once you do put your advance directive into the portal, same kind of question is, well, does it share between states? Or yeah, I want to go states, not just counties, but can it be seen through a portal to another hospital in a different state?
John, you want to answer that?
Well, yes, I'm happy to start. You know, it's really dependent upon your healthcare provider and the specific approach to your provider's stewardship of the advanced healthcare directive. Almost all major healthcare delivery systems in San Diego now will take a completed advanced directive document and through their health information management or medical records and scan that onto their electronic medical record and their EMR. Some are very integrated with their outpatient clinics and ancillary services, where if they're scanned as well in the community, that will populate into the hospital's electronic medical record as well. That's the case with Sharp-Reed-Steely and their relationship with Sharp Healthcare. If you're a Sharp-Reed-Steely patient and you have your document scanned in your clinic, it does populate in their electronic medical record cerner in the hospital, and other agencies have that same capability as well. But they don't share advanced directives across healthcare delivery systems in San Diego currently, and also not across the nation. There are a couple of repositories or registries for advanced healthcare directives. They're not very developed and they're not accessed very frequently. California does have a lightly used advanced directive repository, and there are there's a national effort on that as well. We're actually in our county, we're further ahead in terms of pulse stewardship and sharing that from entity to entity through something called the Health Information Exchange, where different healthcare providers are sharing the pulsed form across the healthcare delivery system in San Diego County. San Diego was one of 2 pilot agencies to try to institute a pulse registry where we would share that across the system. One of the things that I look forward to is a little bit of Amazon-like advanced directive management with my Follow My Health or my online portal that I use to make my appointments and stay in contact with my doctors. My advanced directive and my pulse form really should be in that space, and it's almost always not right now. It's really hard to get your own advanced directive in your own healthcare portal, if that makes sense. And I know that Karl will want to comment some on pulse and advanced directive stewardship as well.
Yeah, I mean, I'd say for people who want it to be easily accessible to somebody if there's an emergency, there are some private companies like, mydirectives.com that you can upload it to, and it's easy to, there's a QR code or something that people can access if you get in trouble. There's this Mideo, M-I-D-E-O, where you can actually take a video of yourself saying, if you ever put a feeding tube in me, so help me God, I will, I will curse you forever, or something like that. And that can be kind of compelling if your loved one is showing that to a healthcare provider. I mean, there you are, there's nothing ambiguous about it. So those are some things that I think in the years to come, we will see more and more use of those types of technologies. Now, Oregon has, and a couple of other states have statewide registries for pulse type orders, like DNR orders or those types of things. And I think, again, that's something that will get more traction. It's kind of expensive and there's privacy issues and whatnot. But there's nothing keeping you from taking a picture of your advanced directive and keeping it on your phone, letting people close to you know that it's on there. And for people who are, more obsessive about this, you can get a bracelet that will direct people to the website that has the information on it and that sort of thing. So those are some ideas.
Would you and John like to share the vial of life and how important that is to place on your refrigerator and what it's in it? I mean, I can take it out to show you, but why is this vial of life important, and is it being used all over the country?
I like that one's from Sharp Healthcare, I believe, the Sharp Senior Resource Center, and they're free if you would like one of those. It's really beneficial for people who have serious or advancing chronic illnesses, and this might be a good time for Karl and I just to really point out that a pulsed form does not replace an advanced directive, and an advanced directive doesn't replace a pulsed form. They're complementary documents, and the advanced directive names your substitute spokesperson. It's for all healthy adults and all adults. And the pulse form is really geared towards people who are dealing with chronic, progressive, or serious illness. And doctors have a very, very serious conversation about things like code status or attempting or not attempting CPR if a person's heart stopped based upon what their wishes are and what their health situation is. It's a very nuanced and important conversation that involves goals for treatment as well. And so if a person has a pulse form, they really should have a vial of life with that strong magnet to affix the pulsed form to the refrigerator, which is where emergency medical services will look for a pulsed form. It also contains important information about medication lists and healthcare decision makers without having to put the whole advanced directive up there. It points to that person's name and their contact information. So that vial of life is a nice tool for people. And I would say for particularly for people who have some serious illnesses and even have a pulse form.
Thank you, John. Is, Christy, I was wondering if you could share with me what's going on at Facebook. Are there any questions over there? How many people are on the call? That kind of thing.
Sure, Michelle. So I've got a watch party going, and I've got a few people on there with me that we're commenting back and forth. And we've also got on our expo page, people are coming and going, and we're answering questions. But right now it looks like everything is good. We don't have anything. When it does come up, I'm going to go ahead and put it in the chat box here for everyone.
Okay, wonderful. Thank you, Christy.
Yep.
Thank you for that update. And next. And so we have 15 minutes on the call. I wanted to ask if there was anybody that wanted to share a story, something that's going on with them, a poem perhaps. I think Teresa, you might have a poem that you'd like to share today. Teresa, I actually met yesterday on a call that we had on just Q&A, share where you are, what's going on with you, how do you feel, anything you'd like to know about or question, or maybe you have a poem or a story. And she's like, I have a poem. I think it's called Lakes. Is that right, Teresa? You're on mute, so unmute yourself.
I think she should play her guitar that's above her head there.
I see.
Yeah, pull down that flying V, baby.
Yeah.
Oh, that's my husband's guitar, and I wouldn't know the first thing about how to pluck it away. I do have the poem entitled Lakes, and it's a bit long. I don't know if it's appropriate, but I could read part of it. I brought it up last night or last evening because it's about my mother, which has got me my recollection of the time spent with her during her death and the last days of her life have, prompted me to participate in this, what you folks are doing. And so I wrote this a number of years ago, and again, it's kind of long, and I don't know that it would be appropriate to read the whole thing, but I mean, I could go for it.
If it's 7:18, is it more than 5 minutes?
No, I could probably get it read in fewer than that, but I'm going to go for it. Okay.
Yeah, I want you to go for it. That's what I want.
Okay.
You go for it.
It's called Lakes, and just a tiny bit of background. I grew up in Rochester, New York, a mile away from Lake Ontario, and I currently live in Lake Elsinore, about a mile away from the lake. And so this poem is about relating those two lakes and my memory of my mother. So here it is, Lakes. Nimbus clouds in their great lumbering beckon me to Lake Elsinore like good friends this morning. A tow truck pulls in the lot ahead of me. The workers open the facilities, and the disheveled wait in the distance and huddles around the trees. I come to the water to look for her. Down the foreshore, swamp decay blusters the air. A stout fisherman dangles his line in the low water. A tub of worms, a promise on his face. A swift seabird, I start after her in a bang to keep from sinking into the sand like I have done on the shore of Lake Ontario, the small Great Lake. There, the forward gulls swoop around me in hollows, shrill and low overhead. I dodge them. The washed up bottles I leapt over, the thin black lines that shined like tar on cracked pavement. The thick east mist blurred my eyes, and she, too far ahead, dissolved into the shore. This morning, I embraced the rain. Among the lady mallards and emerald drakes, a giant egret buoys in the waves. His white wing fans for a moment, like a second thought attempt at flight. I leap over the black lines in the sand like cracks in the sidewalk. I promise I'll never break her back. So that's for my mom.
That's beautiful. That wasn't long. That was short.
Absolutely
Okay.
beautiful.
I thought it was kind of long.
And I love the tar, the dark spots and jumping over, and you'll never break your mother's back. That is so perfect. Thank you so much, Teresa.
Thank you. Thanks for letting me do that.
Yeah, I just, that's quite amazing. I write myself. I was telling you last night, I write poetry from dreams that I have. Very, very vivid dreams. I turn them into poetry. And, but mine are really long, so it isn't happening tonight. Another Zoom call, we'll all tell our stories and share poetry. How's that?
So
Cool.
your poems are too long to put on like a greeting card, huh, Michelle?
I could put it on a greeting card. I think it would work there. Yeah, maybe another time I will read you some of my poetry. I want to, this morning, I just want to share a couple of things. This morning on the call, I don't know if you're familiar with who Amy Cunningham is, but she's a funeral director out of New York City. And on one of her posts, someone commented back to her about some information. And I just wanted to share about Texas and what they're allowed to do, and not quite sure how it works in California, if it's even ever, if it will ever be possible. But there's in Texas, someone could set aside 10 acres of their land outside any city limits and dedicate that land for a cemetery and file that with the property deed. Would take one day, no lawyer or surveyor required. Then allow burials on the ground at 3-foot depth in shrouds, cremation boxes, or caskets. You mark the grave with rebar, stamped metal tag, and GPS coordinates. Keep a record. Home funeral advocates in Texas have done a compilation of the above with 4 natural burial grounds. If you rent a little backhoe, it makes the digging easier. This gentleman did that 4 weeks ago. 10 acres can bury about 2,000 bodies in boxes. And there's no embalming, just hold in the fridge until there's time to bury your loved one. Use current PPE precautions. And it says that in Texas, families can do all the above without hiring funeral retailers. And of course, I think in all the hospitals in the country, and please tell me if I'm right, must release the body directly to the family if requested if they're in the hospital. Is that correct,
I don't know.
John? You don't know.
I don't know that that's the case in California. I'm not sure.
Well, I know that through my death midwifery work in California, if the family wants the body released from the hospital, you have to release the body to the family. That's as far as I know. That's very interesting. It's 7:23. Does anybody have anything they'd like to share before I share something else?
I mean, I was just thinking a little bit about some of the specifics about COVID-19 and the conversations that we have, and John probably has some insights too, but you know, people are already thinking about it. So it's not like, you know, most people aren't taken aback when you ask them, you know, what do you understand about this illness? What do you understand about your underlying medical conditions? And you know, have you had any thoughts about how they might interplay? I mean, we're going to hope that you don't get this illness. And I've been very fortunate that the 3 nursing homes I go to so far have no cases, and nobody suspected of having it. But you know, that's probably just a matter of time. But you know, we're going to hope you don't get it. But we will just want to plan ahead just in case, because it's so insidious. You know, in spite of everything we're doing to protect you, you know, you could potentially catch it. And then what would you want to do? And so then there's the whole discussion about, and we've been also very fortunate in our county in San Diego that we haven't had huge shortages of ventilators or, you know, ICU rooms, you know, taking up the whole hospital and that sort of thing, which is wonderful because people have done a good job of social distancing. But people watch TV and people, you know, the normal discussion about a ventilator is, you know, if you get real sick, you might have to go on a ventilator, but usually if you're going to get better, you get better in a few days because you have sepsis or something. With this virus, you might be on the vent 2-3 weeks. Many people don't ever get off it. and it requires higher pressures to keep the lungs open. And so not everybody wants to get in that level of detail, but some people do because it helps inform their decisions. And I think, the most important thing as a healthcare provider is to say, what we really want is to help you get the types of treatment you want to get, not be put through things you don't want to be put through. And, we're going to walk the path with you. We won't abandon you. Although, if you say that in a nursing home and the patient goes to the hospital, you may not be able to keep your promise, but that's our goal. That's what we say to people is, we're going to stick with you. We're going to do everything we can to make sure you get what you want, and also to respect you and to make sure your comfort and dignity are looked after. John, I'm sure you have something
That's
to add.
beautifully said, Carl. And, I wanted to just say that I had a very tender conversation with my sister, whose husband, my brother-in-law, Ron, was hospitalized in Portland, Oregon with COVID-19 and was on a high flow oxygen and didn't have to be intubated or with a ventilator support, but we were close to that. And we had to blow off his advance directive, and he's an attorney, and it's a very tender conversation in the face of what was hoped to be an acute, reversible, short-term illness, was a long-term chronic expected gradual decline. And those types of conversations are very different. The conclusion of a long, slow decline sometimes has different nuances than the conversation that I had with my sister, which was very kind of much more sudden and a great deal of uncertainty with regarding the illness trajectory.
Yeah.
I wanted to say when I was hearing that comment about the small little cemetery, I was in seminary up in Oregon 100 years ago, and I remember little family plots back out in the woods of Oregon, and how a family would gather and invite clergy to come and be present with them in that sacred space. Very, very holistic, back to nature family context, surrounded by the giant Douglas fir and cedar trees and water everywhere. And so you took me right back there, Michelle. And even in the midst of COVID-19, I start thinking about my own mortality and my own disposition arrangements and what matters most to me. And in that regard, this is such a very, very intimate and personal space to be in. And I'm honored to be in it with you all tonight. Yeah.
Thank you, John. Thank you, Karl. I'm just really excited that, we have people on the call and listening on Facebook who are from the public that are in a part of all of this every day, that, we see things and hearing things and, doing our webinars with our own people. And when I mean own people, I'm saying like palliative care is all, you get like Karl was just doing a webinar a couple of days ago with palliative care physicians asking about the same kind of thing for themselves. And it's, I'm really happy. I mean, this is the joy that I have, is being of service, bringing you, the experts, to the public and sharing what we know, especially now because we're all questioning everything. Topsy-turvy world. How do you find your way through this? I just want to share what we have and what's happening as fast as I can to move things forward, because our expo that we were going to have physically, we're not doing anymore. We're going to do a virtual reality trade show in November. So we're just trying to do these snippets of information so people know what to expect now and how we can all come together in November. And with that being said, it is 7:30. I want to thank you all for your time. I want to say two things. No matter what I do today or where the future takes me tomorrow, I promise to remember all the things you've taught me and how very much you love me. In case I don't say it enough, And sometimes I forget to show it. I wanted to say this so you know I love you too. And I just want to sit with that for a moment. And the other is because you always encouraged me, because you were never too busy to listen, because you've given me one special memory after another. I have so much to be grateful for and so many reasons to be happy, all because of you. And that's how we're going to end the call. And I just want to thank you all very much. We're going to be doing this on a monthly basis, and we'll just continue to move forward. I want you all to just keep coming to the call. Each month, you'll hear about it through Facebook, through YouTube, through Zoom, through personal emails. And I just want to I'm just so very grateful to all of you, and thank you. Thank you. God bless.